Ja, schönen guten Tag. Vielen Dank.
Good afternoon. Thank you very much for the introduction.
Ich möchte Ihnen heute
Dear colleagues, today I would like to present our initial findings from the Eclipse study.
das sind die ersten Ergebnisse.
These are the initial results. We started this study at the beginning of the year when we received the Leica microscope and also the MyVeo headset.
MyVeo.
This opened up some new possibilities for us, and we wanted to find out how much impact this ecosystem could have on everyday clinical practice and specific surgeries. This is why we set up a small study.
Die Studie hat sich vor allem befasst.
The study is primarily focused on surgical ergonomics. In our opinion, this is an area that will play an increasing role in the future.
Wichtigere Rolle spielen wird. Die Ausbildung.
Also, we cover education, meaning microsurgical training, and lastly, the use of the microscope as an exoscope, which includes the switch between microsurgical techniques and digital surgery, also known as exoscopic surgery.
Exoskopischen Chirurgie. Das ist das Mikroskop.
Here you see the microscope, which many of you are already familiar with. It's a great microscope, and we are very happy with it. The most interesting part about it is the new headset, which was recently launched. When we talk about this new addition, we need to also talk about the evolution of visualization. You are all familiar with light microscopy. We are all used to it. Especially older surgeons are very well trained in microsurgical procedures and very good at applying their microsurgical skills. For them, the surgical microscope is almost like an extension of their own body. As we know, there is currently a revolution taking place in the field of heads-up display surgery with high-resolution 4K or 5K displays, which offer 3D visualization when wearing special glasses. What is new, though, is the 3D visualization via a headset. However, it must be clearly stated that light microscopy, as a traditional method taught and perfected by luminaries like Professor Yashirgil, remains the gold standard, and you may not be able to achieve this gold standard with digital imaging. However, it is possible to get closer and closer, especially with the possibility of a digital 3D visualization of the surgical field and pathologies. In the Eclipse study, we focused primarily on the comparison between light microscopy and the new MyVeo headset device, offering a digital visualization. Let's have a look at the device setup. There is a hub and the MyVeo headset that you wear. You can adjust it. At first it takes a little practice, but you can adjust it in a non-sterile environment, and when you're ready, you put it on. Here you see the cabling at the operator's back, which can be attached to the OR gown so that there is no extra weight. The comfort of wearing the device is a really important factor, which I'll talk more about later, especially in the context of longer surgeries. The study design is as follows. We included cranial and spinal cases. Inclusion criteria were mainly based on the necessity of microsurgical treatment, and we included supratentorial, infratentorial, and skull-base procedures for the cranial cases. And for spinal cases, there were basically no exclusion criteria. Included were cervical cases from the front and back, as well as thoracic cases, decompression surgery, and, of course, normal disc herniation. What we did then, immediately after the operation, was to evaluate both, the surgeon who performed the surgery and the assistant. In this context, we evaluated two aspects. First, an objective score, which we will discuss shortly, known as the REBA score. This means that there was always an observer who observed the surgeon or the assistant and a subjective questionnaire. That's the REBA score. For those who don't know it yet, the REBA score is the most established score for evaluating posture. Take a look at this. The semi-sitting positions, for example, during long operations. You are probably familiar with this. And you know that certain postures tend to become uncomfortable over time. After a while, especially the upper arms start to ache. The evaluation of the REBA score or modified REBA score is exactly about these uncomfortable positions. and whether they have any influence on the surgical outcome, but also on the operating surgeons themselves. This is what the questionnaire is about. We have kept it relatively simple. Just attach the patient sticker, note the diagnosis, what we operate on, and the surgical approach. Next, we add the spinal and cranial details. Then the subjective questionnaire part follows. We use a 5-point Likert scale to evaluate various aspects. These are the cases we have evaluated so far. We have done cranial cases, like meningiomas and aneurysms, but also ventricular space-occupying lesions and some spinal cases. Like I said, these are just the early results, and we're hoping to wrap up the study in September or October. We are still looking for participants. Let's move on to surgical ergonomics. This is the posture we should actually adopt during surgery. In this ideal position, you sit, and your arms are supported. We all are familiar with these standard microsurgical techniques. It is all about reducing tremors and being able to operate in a controlled manner. For the assistant, it can be even more challenging to find an ideal working position. As you see here in this picture of my colleague, Mr. Rock. He's sitting here in the audience, and he's a bit taller than me, and when I operate, Mr. Rock has to strain himself. Sometimes it is the other way around, though, and I have to adapt my working position to the operating surgeon. The semi-sitting position can also take its toll on the arms over time, as I mentioned earlier. And, of course, there is an even more impressive example. Our clinic director, Professor Sandalcioglu. He actually performed a 6-hour transtentorial operation on a thalamic tumor, and he did so in this position. It is easy to imagine that working like this for 2 to 3 hours can have an impact on your fine motor skills. Not in his case, of course, but it's easy to imagine in theory. We know that 88% of neurosurgeons have work-related musculoskeletal symptoms. This means that they have actually already been experiencing symptoms during their training. Most of these symptoms occur immediately during surgery. This is important to mention because it is a factor that can have an impact on the surgical outcome. When neurosurgeons start their specialist training, they are still healthy, but afterwards most of them suffer already from back pain, tension, and similar problems. We surgeons always tend to ignore that and kind of push it aside. But it's not something that will simply disappear, so we can't just ignore it. I think we should pay a little more attention to this in the future. The ideal surgical position is this one. You sit with your legs and arms bent at an angle of slightly more than 90 degrees. In this posture, you can operate the best. There are, of course, also risk factors that arise due to the specific patient positioning. For example, sometimes you have to choose a different trajectory if you want to achieve a more subfrontal approach. In such cases, you have to strain yourself because you simply can't tilt the operating table endlessly. Another aspect is equipment-based risk factors. For example, if your microscope is large. I don't want to go into details about the different microscope manufacturers, as you are probably familiar with the studies about the semi-sitting position and the question of how large the microscope housing can be in order to be able to reach the surgical field. And all of these aspects are risk factors that must be taken into account. Have a look at this snippet, which is from a MyVeo surgery that I performed. What is remarkable is that you can approach the tumor from the side, as you can see here. This was a sphenoid wing meningioma, so it wasn't large. MyVeo made it easier to see the surgical field without having to strain yourself, and I could maintain this working position. Another crucial factor is that the assistant does not have to adapt the working position, can keep an eye on the entire surgical field at all times, and can assist better. In general, with the MyVeo headset, the ergonomics are better. Or in other words, the risk of developing musculoskeletal problems is no longer as high, though some risk always remains. Overall, it can be said that our interim study results have shown that when you operate with MyVeo, this can have a positive physiological effect. Let's talk about surgical training. We have asked the assistants, and what we've found out is that most of them are enthusiastic about MyVeo. There are various reasons for this, and I'll include my interpretation. Our assistant doctors, especially the younger ones who are just beginning their training as neurosurgeons, are not yet so dogmatically trained in microsurgery that they are completely dependent on a surgical microscope. They are much more technically savvy, and thanks to the physical freedom offered by the headset, they prefer the view of the surgical field via the headset. Their visualization ratings were overall good, and above all, they did not experience any physical strain, which enabled them to follow the operation more effectively. My last point is the use of the system as an exoscope. What we've observed so far in the study was that the visualization quality of the headset was rated generally good. The prospects were able to see specific aspects and details very precisely during the digital surgery. However, there was actually a so-called switching point. And this switching point is crucial because we know that certain surgeons, especially when operating on aneurysms, for example, they like to revert to what they are used to, at least for a few critical surgical steps. Some of you may be familiar with this situation. For example, when performing microsurgery on the pituitary gland and then wanting to switch to endoscopy to learn it as a secondary practice, you want to have the microscope available for safety reasons, at least the first few times before taking the plunge. We have observed a similar phenomenon in the study with MyVeo. Quite some colleagues have actually, at crucial stages, made this switch to the surgical microscope. Not because the exoscopy was worse, but simply out of habit. Some respondents stated this very clearly in the survey. Overall, the MyVeo is a great device that you can use well. And what makes it special is that you can switch during the operation back to the microscope. This means that you don't have to make a decision and say, I'm only going to use the surgical microscope optically, or I'm only going to do digital surgery. Instead, you can actually use both and switch between the two different visualization options. A study like this isn't done alone, of course. This is our team from Magdeburg. Thank you very much.